Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear me clearly. If you wish to claim your certificates for the same, kindly visit our website, which is www.onlinedentistry.in/9 p.m. and register for the same. Once again, welcome back to the free online session of online dentistry at 9 p.m. with yet another amazing faculty. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. The motto we preach is to redefine dental education. It has been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in 2008, so far we have covered over 203 offline courses and have conducted 1,022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Binuti Abraham, who is our finest practitioner in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Aluva. Currently, he is interested in educating thousands of clinical practitioners through online and both offline sessions. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter. Currently, he is the HOD of Department of Pediatric Dentistry at Anu Dental College, who preaches the philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. The latest addition to our courses, the one-year comprehensive and advanced master training program on interceptive and myofunctional orthodontics have been successfully initiated with 2 batches, and we are now open to take up students for the 3rd batch coming up in September 2023. So this is a multidisciplinary approach with intense training and hands-on session under a team of eminent faculties, including our own Professor Dr. Joby Peter and Dr. Binuti Abraham, along with Dr. Monica Sharma, ENT surgeon, Dr. Shahin Shukur, pulmonologist, and Ms. Ahana, speech pathologist. Yet another 3-day program is about to come up on the 10th, 11th, and 12th of February at Chennai. It will be an amazing workshop on interceptive and myofunctional orthodontics. You all can catch up with the details on our website, which is www.onlinedentistry.in. Online dentistry have been conducting sessions all over India for the past 14 years. During the lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from the dental fraternity. In the year 2023, we are relaunching the same by providing free advanced learning series under the online dentistry at 9 p.m. So stay tuned for the future sessions on facial aesthetics by Dr. Chirag Agrawal, TMD disorders and their management by Professor Dr. Deepak Daryani, the do's and don'ts in dentistry by Professor Dr. Sivi Vipalayatha, and finally, our today's session on clinical guidelines on all ceramic selection by Professor Dr. Mohan Bhuvaneswaran. You can also feel free to reach us on our WhatsApp numbers, or else you can visit our website on www.onlinedentistry.in. So, our topic for the day is clinical guidelines for all ceramic selection. So, without further ado, let me move on to introducing our speaker for the day. Dr. Mohan Bhuvaneswaran secured his master's in conservative dentistry and endodontics from Government Dental College under the Dr. MGR Medical University, Chennai. He started off his career as a teacher at the dental school from 2001. Further, he headed the Department of Conservative Dentistry and later took over as the Associate Dean of SRM University and served in the position for 1 year. He owns a multi-speciality clinic in Chennai and works as the adjunct professor at MEHSA University, Malaysia, and Guru Nanak Dev Dental College and Research Institute, Sunam. He is a visiting professor at Sri Ramachandra University, Chennai, and University Airlangga Surabaya in Indonesia. He is the accredited member of AACD and started the first study club which is affiliated to the same. He started a training center and serves as the chief academic officer there, training postgraduate practitioners in the field of cosmetic dentistry and motivating them towards accreditation. Presently, he is a board of director of AACD, the founder president of Academy of Cosmetic Dentistry in India, an affiliate of AACD. He served as a joint secretary for 9 years and general secretary for 5 years for the Indian Association of Conservative Dentistry and Endodontics. He is the past president of American Board of Cosmetic and Aesthetic Dentistry, preceptor for residency program for AACD, the president-elect of Asia-Oceanic Federation of Cosmetic Dentistry. He has been credited with more than 35 publications and have received fellowships from the Academy of Dentistry International. He delivers lectures and hands-on training in cosmetic dentistry in India, Asian and Middle East countries. He is a recipient of numerous awards: the Smile Center by Famden, Outstanding Dentist of the Year 2015, the Best Cosmetic Dentist by Lifestyle Awards India, the Best Affiliate Leader of AACD, and the Best Clinician by CEAT. He has won the Famden Superstar Award and is a recipient of EVY Award for Outstanding Service in the field of cosmetic dentistry by AACD. He is also the recipient of Excellence in Restorative Dentistry Award by the International Award of Excellence in Restorative Dentistry. He received the CEAT Icon Award and is the branded educator of American Academy of Cosmetic Dentistry. We wholeheartedly welcome you to the platform, sir. Over to you.
Thank you so much, Dr. Nita, for that beautiful introduction. It's a pleasure to listen to you, and a very good evening to all our participants here. Thank you so much for taking your time out later this evening to learn more on today's topic. I welcome each and every one of you for this online dentistry platform, and I'm really thankful for this online dentistry for creating such a big platform for education. It's very important these days, especially when you ask me, there are so much advancements happening in every day in and out. So it's really important that we learn the best, and the best is learned only by continuing dental educations without any doubt. So without any further delay, a warm welcome to all those who are gathered up in this online platform Zoom and also in the YouTube channel. Today, I know you must be knowing the topic, the clinical guidelines for all ceramic selection. I feel that's a hot topic. Whenever I ask people, they will talk on this. So why? What is happening here? What is the problem, or what is as a clinician, where do we find challenges in a restorative work? So primarily, a restorative complex, what we create, can be either directs or indirects. And when you look at our practice, I would tell that it is 50-50, directs and indirects. So when you look at a larger case, it's mostly indirects. So selection of these indirect materials are becoming more and more a challenge. Why? Because is that everybody is dependent on the lab technician. As clinicians, I don't know how many lab techs are here. As clinicians, nobody, no company is going to come and sell a ceramic to any one of us unless and otherwise we own a laboratory. So how do we get to know what is the latest? If it's a composite or a bonding agent, every other representative is going to come and talk to us. But a ceramic is never sold to us. So where do we get the current concepts? It's very difficult because what is got in the literature is just a fallback of what is available in the market, which is 2-3 years back. Something has changed now. So here is where the problem which was not there, the challenge which was not there years back has suddenly come up because one is the material science that is changing, and the fabrication of them is making more simpler, and putting them onto the tooth is a different category. So today, how do you know how much of tooth to reduce? Absolutely, it's material oriented. So today there is nothing like tooth reduction guidelines. It is tooth is reduced as much as required to receive the restorative material. So your knowledge on the restorative material is very, very important. So in this presentation, I'm not going to show you that use this ceramic for here, this ceramic for here, then it's done. Then I'm not giving you anything in this lecture. So in this 15-minute lecture, what I'm going to plan is not to make you what to think. That is not a good educator, actually. A good educator would be how to think. If a case comes, you need to think how to handle that case. That is what is very important. So in this all this presentation, I'm not going to get with use this material, use that material, I love this product. No, nothing. I'm going to guide you to make your own decisions. So today, somehow the all ceramic is very, very popular due to few reasons. Because of the optics. The optical property is nothing but the look. So we have two major things. One is the optics, that is the look or the aesthetics, and other is the functional component of it, which is the strength. So the look of the all ceramic restoration is really, really great. And that's the reason more number of us are selecting towards the all ceramic restoration. The gingival margin is good and the KOSF is beautiful. And these are the few advantages of an all ceramic restorative material. So before going on to the actual pros and cons of each material, I want to make one thing very clear as a disclaimer here that I am not talking this lecture for any company or something, but it is a pure scientific fact that is presented right in front of you the next 45 minutes. And I'm not supporting any particular material. My job here is to help you make your choices wisely. That's all. I'm going to guide you to guide you. That's all. How will you make your decision is what is the guidance of this presentation. It's not a PDF telling that when this situation comes, this is a material object. When this situation comes, this is no, no, no. That is wrong. You have to select according to the situation. So I'm not going to put a theory presentation here. It is clinically relevant. So when this case comes, what should I do? How should I process? And accordingly decide my tooth preparation. So this is what I earlier told you, what is the advantage of the all ceramic restoration. Coming on to the evolution of the all ceramic materials, when you see that it is tracked at early or late 1886, 1885, that's when platinum foil technique came up. So it is so old, ceramics is so old, and all the concepts of composites are borrowed from ceramics. Simple as that. So how do we layer? We find how ceramics are getting layered. We do that. How do we texture? How ceramics are. So ceramics is the birthplace for restorative, indirect restoratives. So that's when they started to replace tooth structure with ceramics. Then slowly 1955 Bowen introduced BGMA as a direct restorative material, and that's when we had this composites. So here you see how much changes went into it, and finally in 2005 was the breakthrough for us, wherein Emax was introduced. Also zirconia came into the market, so not very late. So after that, a lot of pitfalls, everything came up, and it's a very recent topic wherein 2010 or something only everything got refined. It's hardly a decade. So that's when we have so much of material sciences that have developed in the recent past. So when you're looking at all ceramics, there are four materials that are available to us: the feldspathic, the lucite glass, the lithium disilicate, and the zirconium oxide. So these are the four materials available. And if you ask me, the first three is a glass ceramic material. And the next category is an oxide ceramic. So this is how we broadly classify. I will not push you more than this. If you know this, that is, I'm not going to take you in this late night dinner time. Come on, guys, this is the physical property. This no. Let's forget all that. Clinically, how does it apply to us? So feldspathic ceramic is just with a powder slurry. Afterwards, they increase the strength and the aesthetics by improving on the strength as lucite glass. Then what happened is lithium disilicate was introduced as an emax, then came zirconium oxide. So broadly, I would like to classify them as glass ceramics and oxide ceramics. Okay, glass would include the feldspathic, lucite, lithium disilicate, aluminum oxide would include the aluminum, zirconium oxide. So in this, what is very popular? Lithium disilicate, which is popularly known as emax, and of course everybody knows zirconium oxide. So we have two materials now, two elephants in the room, I would call. One is Emax, one is zirconium oxide. Primarily, even if you ask me, majority of my work will revolve around these two materials only. So when do I select the other materials? It's very few. If you ask me, 99% of the work would revolve only these. Other come into play a very little. So when you look at the strength, there are multiple factors which you need to look. So if you ask me, aesthetics and strength. So these are the two things keep in mind before selecting a material. Where do you need aesthetics? Where do you need strength? You cannot tell a patient that, hey, come on, put a beautiful material there. Don't do anything other than smiling. Your patient is going to kick you out. I want to eat with that. That doesn't mean, on the other hand, I'm going to put a stainless steel crown. Come on, guy, you can eat anything. Again, the patient is not going to like. So it's a balance what we create between the look and the strength. So the optical properties of the material and the physical properties of the material, this is where we balance and get it out. So please remember one thing, very, very simple equation. I made it as simple as possible. As I promised you, I'm not putting those values here. I'm not putting anything. Very easy to remember is that this one, not even this one you have to remember. When aesthetics improves, strength drops. Simple. That is all is the equation. When something is looking good, obviously the strength is not very good. So when your aesthetic requirements are high, obviously the strength of the material is getting compromised. This rule is not going to change. So on the scale, I told you we have feldspathic, we have lucite glass, we have lithium disilicate, and we have zirconium oxide. Obviously, feldspathic is the most aesthetic material that is available in the market today in the world globally. Next comes lucite glass, next comes lithium disilicate, finally comes zirconium oxide. So in this order, strength. And so when you aesthetics drops down, automatically the strength improves. So I don't have to tell which is looking good and which I don't. This is a scientific fact. I'm not here to prove which looks good. I'm presenting the facts right in front of you to make your own decisions. Fine. In this, you need to understand one more thing. The one more thing is that why the gray box is that only these two materials can mask discolorations effectively. So here, what you have to realize, okay, I have a high-end aesthetic case. No. Strength is also important for me. So then you drop down to these two materials. And then depending on the situation, you select either of this material. No. My aesthetics is very good. It's okay. It's a very, very beautiful thing. I'm just doing a no prep laminate or sufficient thickness of the material. Then I would wind up with a lucite glass also. But at the moment discoloration sets in, then I have only two choices left out of the four materials going to be lithium disilicate and zirconium oxide. That's called nothing else can mask discoloration. The next most important, today, we are all dependent on adhesives. Why? Conservative dentistry is today completely changed because of bonded dentistry. Today we call bonded dentistry or cemented process. Why bonding? Bonding drastically reduces the necessity for tooth preparation. Am I clear about it? So if bonding is possible, then obviously your tooth reductions are very, very good. There is a small trick here. This is the third factor. So I've already told you aesthetics, strength. So when aesthetics is high, the strength is going to drop. When the material is stronger, that simply means it's not an aesthetic material. Finally, I'm going to tell where you're going to put it. It's a bonding. So here, I'm not talking, it's all literature support actually. We do have a predictable bond with glass ceramics. Whereas with zirconium oxide, it's still a question mark. Today, I'm talking today. Maybe tomorrow or day after, some things may change with zirconium oxide, because today it is only thing that we revolve with literature is the so-called APC technique. You can see everywhere the APC concept, the APC technique. What do I mean by APC? Is that you air abrade like how we do the metal restorations, then apply the primer, then put the composite resins. So you get a good bond, but not as effective as what we achieve with glass ceramics. So there is always a question mark. Will you do a zirconia laminate? In my personal opinion, I have my own things that okay, I have my own restrictions. I have when I can do it with glass ceramic, why will I want to push it to zirconium oxide? So zirconium oxide, I'm not telling a complete no, because there are articles that are published with follow-ups, but why do I have to really push it when I have a better material to do with it? That would be my argument. That's all, nothing else. I would love to work with glass other than actually working with zirconium oxide, because the bonding is still a huge question mark. Why? Because is that a laminate is a non-retentive prep. A non-retentive prep is where cementing is a primary mode of retention. When cementing, I'm then totally dependent on cementing. I would not want to compromise there. So the next factor where we lose out is processing. We always feel that I take an impression, send it to the laboratory, hey guy, do an A2 ceramic bond for me. That's all. There ends the matter. No, there doesn't end the matter. We have to realize that the processing is also important. And today, without knowing the processing technique, it gets very, very difficult for us to understand. So we can either do this completely handmade, where they do the feldspathic, everything is individually crafted. The minute hand work is going inside, the cost increases. So if you ask me, the number of people who do this work are very, very, very minimal. Expenses are very high. For me, my friend in Los Angeles, Eric, does it in Hab Dental Laboratory. It's 400 USD. So it's expensive and also very time consuming. With the advancements with analogs and digital dentistry, more and more of using feldspathic ceramic is coming down. So handmade restorations are still a very minuscule portion of a restorative world, and not many would be interested in that. Mostly we revolved around analogs, wherein we do the wax patterns and then do that is also primarily done, but only thing again, manual component is involved in this, and other is obviously digital. So today, more and more people talk about digital, and then it's easy, it's more predictable, and then the human error is gone, and number of people involved, number of time is absolutely reduced. So we don't have to actually go into it and then work on. So we have two modes. One is analog, and other is digital. You always choose in which mode you want to process your restoration, then go into the finer details. So I'm going to divide this into two. One is the glass. First, we'll analyze what is about glass, and next is oxide. As I told you, we have two broad classifications. One is the glass, other is the oxide. So first we'll discuss glass and then move to the oxide. Glass. Glass starts with lucite glass, which is more popular as the Empress, IPS Empress from Ivoclar. So this is where it started, and another company offers this actually. So this was a breakthrough from feldspathic. Always they wanted to increase the strength, because feldspathic is so fragile. If a person is not trained enough to do that, then it's very difficult to, basically we do laminates, we're not going to do crowns. So it's going to be very difficult for you guys to handle. So they improved the strength. And I also, when I started more on it, is when a block came. So this is a CAD-CAM block. You can clearly see if you're watching in a monitor, clarity monitor. It's graded actually. So we have the translucent zone, we have an opaque zone. So it automatically gives a beautiful result. So imagine you have a table and you're putting a glass on top of it. Why do you put a glass on top of it? Because it looks beautiful. So you have a case where there is no discoloration, absolutely something you want to change very minimally to make it look beautiful, probably changing the shape of a canine to a lateral or something. I'll show you a case here. Look at that. I have a canine which has to be changed to a lateral. I have a peg lateral, which, so nothing, no strength factors are very minimal, but the aesthetic requirements are very high. So these are very idealistic situations wherein I can use a lucite glass. A lucite glass is nothing but Empress. So here, look at that post-operative. It completely blends. It completely blends, and the aesthetics is extreme. The patient smile, it's integrated with the patient smile. So this is the level of aesthetics we achieve. But the only thing is that when you're selecting this material, there should not be discoloration and there should be sufficient thickness and it should not overhang anywhere so that you don't, that is, it's a clean table, you're putting something on top of it. Then it's okay. The situation that come to our office in that category is going to be very, very small. That's why I told you 99% it's either Emax or zirconium oxide, lithium disilicate or zirconium oxide. So let's see with a lithium disilicate. Why is Emax so popular globally is that lithium disilicate was found by Ivoclar. And the minute it was there, it was already patented. So what happened was nobody else could do. They could do only hybrid ceramics. We have Lava Ultimate from 3M. Then GC also have a hybrid ceramic. So these are hybrids, but actual Emax was patented and nobody could do it. That's why everybody wrote Emax, Emax. Close the eyes and tell what crown do you want? Emax. So Emax is a family which has so many materials in them, right? So more popularly, it's a lithium disilicate. Please don't think that Emax is equal to lithium disilicate. So one of the family member of the Emax system was lithium disilicate. And that's the reason why people talk Emax, Emax. And today it's all split up. Everybody's their own lithium disilicate now because the patency is gone. So what with this lithium disilicate is that this is the simple composition, but what is more important I want you guys to see is that you see in this block, medium opacity, high opacity. Okay. So when it's MOHO block, what is important for us? Not the shade. That's why people get confused. So here, these are the blocks that are available in the market. So please do not select shades with Emax. You have to select the translucency level with the Emax first. So what I select is that when there is absolutely no discoloration to mask, then either I select an empty block or an LT block. So the first thing I call up when I have a case, the first thing I call the laboratory and find out is that, come on, we don't have discoloration. It's bright and beautiful. So let's select an empty block or an LT block, because the more the translucency, the darker the restoration gets. So that's why we said that the manufacturer instructions gives to inlays and onlays. So if there is mild discoloration, the LT block. If there is an endodontically treated tooth, when there is a discoloration to mask, then MO block, not more than that. So first, what you have to select is the block. Hey guy, what? Because the more and more opaque you go, the more and more aesthetics you lose. People always tell that A2 Emax. A2 Emax doesn't mean anything. Doesn't mean anything. The same A2 Emax in my hand would be different, in somebody else's hand would be different. So please, my request is that when you call up the laboratory, please discuss the case with the laboratory even before you put your aerator handpiece in the patient's mouth. Do not do the tooth preparation and select the material. You are practicing at least 5 years back to industry now. I'm sorry to say that statement very wrong, because today material has to be selected, processing technique has to be selected, cementation has to be selected. Only then does our aerator handpiece goes to the patient's mouth. So here we have the empty block, LT block, and the MO. From then you go ahead and start selecting the shades according to our. So that actually is secondary to me. Selecting the block is very, very important. Now coming on to analog and digital. I don't know, many of you would be having the Cerac machine. Those Cerac machine guys are have to crystallize the restoration, because after the mill, we need to strengthen, and that process of crystallization takes 20 minutes. Here is a graph, what you see. So we have the blue colored one, because to tell the technician or the clinician that it has to undergo a particular process. So we have partially crystallized for the CAD-CAM technicians. So CAD-CAM will be done, then it undergoes a heating treatment, which is called crystallization, which is chemical transformation from lithium metasilicate to lithium disilicate. And so if somebody is using an analog press technique, then they directly use this lithium disilicate itself. So there are two blocks that are available in the market, one for analog users, one for CAD-CAM. What do I mean by analog? Analog is what now generally people do, because that is a cheaper version. CAD-CAM is slightly more expensive. So they do the wax pattern, they get the wax pattern invested. Then what happens is that we do the burnout, then we do the pressing, and then we take it out. After we take it out, we put it on the model and start working on it. So this is the analog part of it. If it's digital, we have the digital blocks, and you know that what happens, everything gets milled. And once it's milled, there you have the restoration there in the hand. So now the restorations are there. Let it be Emax or zirconium. We have to understand one thing. It's like baking a cake. I'm sorry to initiate your appetite at this dinner time. This cake is never a birthday cake, right? Anybody will know that this cake, you don't want to be a birthday cake. This is a plain cake, tea cake. So your restorations are out of the processing system. Then comes a decoration, right? So how much you decorate depends on the situation. Yes. So if it's a birthday cake, it's a different thing. If it's a different situation, if my kid wants something to be painted, I paint. The same thing applies. That's the reason. So my birthday cake, I want it to be fully decorated and like this. So this decoration also happens with the restoration. So the more and more you're looking into beauty, the more and more you tend to decorate on top of it. If you do not have the space to do it, then you paint it. And if you have localized spaces to do it, then you do localized decorations. So in dentistry, what it means is that you layer it, you paint it. It's called staining technique, and then you micro layer it. So this is exactly what we do in our cake, which I showed you. So guys, processing, analog, digital, that's a different story. Your cake is out of the oven. Depending on the situation, I'm going to show you, now you'll understand. With the cases, it's easy to understand. My case needs to be beautiful, damn on earth. I want a beautiful restoration. Then the only way to get it is to layer it beautifully. The minute you start layering, you see the beauty that's coming out. Okay, I can do layering, I can get aesthetics, but look, I have a case where I have no room to layer. I just have room to paint, like a cake which is painted. Painting or staining is not an easy process. Sorry. We actually need a beautiful masterclass technician to do it. And next is that I have room here and there, not everywhere, especially probably in the middle third I have, in the incisal edge I have, then I micro layer. See how much you have to communicate to the laboratory. It's not taking the impression through, hey, 2 ceramic crown. No, that's not the way. Okay, look at this case. We have done this case. We're going to select a lithium disilicate, zirconium oxide. How do you want to process? Analog, digital. Now, what block are you selecting? What translucency level you're selecting? Then what shade? Then are you going to layer? Are you going to stain? Are you going to micro layer? So accordingly, my tooth preparation will be started off. So let's see some cases so that you'll understand what I'm trying to tell. Now, this patient dropped into me. Somehow she was not happy with the crowns that was proposed to her, and she came off with attempts to me. And then I thought a simple crown I'll manage, but I'm not happy with what was happening to me. So this is already done. So I have nothing going back. 2 crowns. When it's 2 crowns, please remember out of the 4 materials, there is only 2 materials that you can do, either zirconium or Emax. That's all, lithium disilicate. Other things will not come into picture. So you're narrowed down to 2 materials. Now, once I do endodontic therapy, there is always a chance of it changing color in due course of time. So even though now it is fresh and I have nothing to change colors, I will select an MO block, anticipating that 5 years later, the tooth may change color and I don't want to show it through. And I have enough thickness already there. And so I'm going to select an MO block, so medium opacity, and then I'm going to layer on top of it because my patient's aesthetic requirements are very, very high. So I will do only in the label layering. Today, nobody does paleting layer. So only the label segment would get layered. My strength is not getting compromised. And I can finish up this case with Emax only. I don't have to push it to zirconium oxide because individual crowns, always my preference would be an Emax, unless and otherwise it's extremely discolored. I'm going to show you all variety of cases so that you get to know what to select where. So what aesthetics is very high requirement for this patient. I need to satisfy this patient because this patient is a very finicky patient who wants best aesthetics. So look at that. So that is lithium disilicate, which is layered. This is what is the aesthetics you can achieve. So I have only one concept. It's extreme aesthetics. And when you're doing aesthetics, your restoration should practically disappear. This is what we call invisible dentistry. When that has to be done, only the layering technique will come into picture. Please remember that the best aesthetics comes only when you layer. So understand the concepts and then put it. So layering is the only way to get the best aesthetics. So all these instructions will really give you the best things. Please, it's not excellence. We talk about excellence. Excellence is not doing extraordinary things. It's doing things in an extraordinary way. That's what I told. Amazon doesn't do great things. It does things in a great way. That's all. So it's a crown. That's all. I've not done anything big here. But the recipe for the crown was completely, that was a deciding factor for the outcome of the treatment. That's all. Again, here, patient wants to change 2 peg laterals. Is there discoloration? No discoloration. So I am totally dependent on a bonding procedure. No prep dentistry. Absolutely no burr mark, right? Nothing. So I'm just going to change the shape, no discoloration. So when it's bonding, I have four materials now. Feldspathic, lucite glass, lithium disilicate, zirconia. Zirconia is out of the place here because I want to do bonding and it's going to be extremely thin, 0.3. When it's 0.3, when you're doing no preps, when people here, I don't know how trained you guys are, when people are talking about no preps, it can be done only with lithium disilicate, mostly because the thickness is just 0.3. It's very difficult. So here, I don't have enough room for layering. Layering means 1.5 mm clearance. So I need to put the material, I need to layer. So here I can only paint. It is called the staining technique. So in this staining technique, look at that. These are two ceramic laminates done with lithium disilicate and just painted. So this is when you need a masterclass technician to do all this. So please remember that everything is possible in dentistry provided you know how to handle them. Fine. So we have two major techniques to be. It's not only about analog and digital. After that, final our hands play a huge role. These are digits. This is digital dentistry. Finally, at the end of the day, it makes a huge difference, right? So please understand that we need to know. So this is again a case of no prep dentistry, wherein the patient requested to change a smile. So the teeth were retroclined. I wanted to bring it outside. And then I had room space, especially in the incisal edges where I can layer only in the incisal edges and paint. This is a mix and match. So I can paint, I can layer is micro layering technique. So this is where nothing was touched again in this case, except for gingival correction was done and no prep laminates done from premolar to premolar, right? So processing technique can be analog and digital. That's a different story, but you need to decide whether you're going to layer, whether you're going to stain, and whether you're going to micro layer. If a dentist doesn't know this, it's very difficult today because you will not be able to achieve what aesthetics we are talking about, especially with regard to indirect restorations. Fine. So it's not everybody does laminate. That's what I told you. Everybody does crowns. Everybody does everything. But what difference are you making? Ask that question. You don't want to be the next door dentist. You want to be somebody great. Then you need to spend time. It doesn't stop there. People always ask me when I come to full mouth rehabilitation, what material choose? Zirconia is very strong. Should I choose that? No, guys, I have a huge follow-up. Our journey started in 2005 when Emax was introduced. Nobody knew how to do it. It was all new. Our lab technician here in India didn't know it because the training has to come from Switzerland. By the time we mastered it was 2009, 2010. Then we built cases from then. We can do full mouth reconstructions with Emax. It's a huge question what people ask me. 28 teeth reconstructed with Emax in this case. You can confidently do, especially in posteriors where my strength is more of my requirement. I would not even bother to layer anything. I'll just paint it and put it off inside. Whereas in anteriors, I would layer, lower anteriors, I would paint. So you need a good technician. You need a good thorough knowledge to make sure that your dentistry stands out in a better way. This case all is 7 years done, 8 years done. Patient is really, really happy. You can see that how beautifully Emax can work or lithium disilicate can work for all cases. So it's not that always we get stuck with one particular material. Every material can help us. Again, coming to implant processes. Somehow everybody wants to put an implant. Yeah, I do agree. Implant is very, very nice. That is the best mode of treatment of replacing a missing tooth. But when it comes to implant aesthetics, it's always a backseat. It's okay, you have a tooth. No. If you have a tooth missing in an anterior aesthetic zone or in the posterior, function is more important and aesthetics is more important. So look at this post-operative picture. So it is completely vanished. So here, please, whenever you're doing an anterior aesthetic work, think about a hybrid abutment. Hybrid abutments are tie base and then I put a glass on top of it. So when I put a glass on top of it, then that is getting inserted. That becomes like a crown prep. So we do a crown prep on top of it and then I do a glass ceramic crown on top of it. So glass looks beautiful. Glass looks beautiful. People always ask, success rate, what happened? Come on, it's been for so many years. I have enough number of literature to support and tell you that we have a lot of work that's been done to, even I myself have a long track story. Like I told, I started in 2009. This is a 2010 when occlusal rehab case was done. Now it's 13 years done. This patient maybe will be coming in for a review for me this year because there was a break in COVID. They could not come. Look at that. What more do you want? What more do you want that this survives and more? That is a huge drawback where people think that with glass, I don't have strength. Can I do it in my posteriors? No, you can do it in your posteriors. It's not that always you get stuck with one particular material. So what can I fabricate with glass? You can do an inlay, you can do an onlay, you can do a laminate, you can do a crown, provided it's stain or cutback technique where you do micro layering. But I would not support a bridge. Though the manufacturer's instructions would tell that you can go ahead with a bridge, sorry, I would not strongly recommend to do a bridge because there is a particular dimension in which the bridge has to be fabricated. If the laboratory is not following that, it results in a failure. So don't burn your hand for bridges. For bridges, we have a good material, zirconium. So let's stick on to this material when the material options are plenty. Why do you want to mess ourselves with that? So now that was the story of the glass. So please be confident about glass. That was the only end of summary of that part. Now coming on to zirconium. So what happened is that when something was getting patented, others wanted to introduce a much more stronger material than that gave birth to zirconia. So people thought that, oh my God, I'm having a stronger material. So the confidence improved. So it will not break. It will not break is what nobody wants in dentistry. So I don't want my crown to break. I don't want my restoration to break. That is an inherent thought of a dentist that my restoration should not break. So imagine I have a glass table. Sorry, I have a iron table and I have a glass floor. And every time somebody is going to come and hit with a hammer, the iron table is not going to break, but what is underneath is going to slowly start to crack. So we need to understand what we are doing. So what is this zirconium? So I'm again sorry to bore you on this. This is a late night for me, if you ask me. Um, this periodic table, which nobody wants to see, especially as a dentist. You see the atomic number of 40. The 40 stands for transitional metal. Actually, it's a metal. And the next question, what you want to answer is that what is the difference between a metal and a transitional metal? A transitional metal is a one which does not oxidize on its own, but when you oxidize, it will get oxidized. So in this process, you can color them. That's when you put white color to it and sell it as an all ceramic restorative material. So it's actually not a pure metal. It's a transitional metal, which is very stable as a zirconium oxide. So what happens is that look at a radiograph. It is as radio opaque as our metal ceramic crown that is in the bottom of the slide. So it is actually has the same level of opacity of the metal. You want to look how a glass looks very soft. So this is a glass ceramic Emax crown and a radiograph, and that's how it looks. So you can do good aesthetics, but it's a challenge to get that done with zirconium. Now this is a crown in the right central incisor. The patient was not happy because it was always looking artificial. How much ever you do, it was more opaque. So now they had to work on this. This was the now strength was high. Like I told you in the beginning of the presentation, the strength is increased. What happens? Aesthetic decreases. Now slowly the demand increased for aesthetics. People were happy with zirconia, but they were not happy with the looks of the zirconia. So generations of zirconia developed. You know what happened? When the look improves, the physical properties reduce. Look at generation 3, which we are living today, has negative mechanical properties compared to the one which introduced the 1200 MPa. So 1200 MPa is the biaxial flexural strength, which is not at all required. When ceramic teeth was introduced, people are telling what will happen to my opposing tooth. With 1200, you know what will happen? It's like an iron table on a glass floor. Your periodontium is going to break. Your TMJ is going to break. We don't need that strength at all. So today they've dropped down to minimum of 750 to 850 MPa. So from 1200, they've dropped down to 850 because that is not the strength that was expected by us. If you know the PFM, porcelain fused metal, is 450 MPa. Your Emax is much more than that, 500 MPa. So we require only 500, 600 MPa. That is all. So now the current generation of zirconia is 750 to 850 MPa. That means your strength is dropped down. That simply means that it gets translucent. It gets translucent. It gets more aesthetics. That is all. So these zirconias are more expensive than stronger zirconia. That is the ironical part. So whatever the lab comes and tells you, doc, premium quality, I don't know what it means. Simply, it means that if the expenses are more, if they are more aesthetics, if they are more aesthetics, the strength is low. That's all. Look at that. So we have the 3y, 4y, and 5y. You see that this is the tetragonal phase and the cubic phase of the zirconia. The more the cubic phase gets into, the more the aesthetic comes. More the aesthetic comes, the strength reduces. Can you see that? This is how you select the zirconia. It's not that blindly platinum premium. I hate that terminologies because more and more dentists have to get educated. So we have a lot of companies. This is one of the examples which I want to give. Go to the company which you're doing zirconia. We have Ivoclar, we have Aman Gurbag, we have Sage Max. Every company is there. Zirconzan. These are very, very popular stuff. Zirconzan, Aman Gurbag, Ivoclar, Sage Max. Ask that laboratory guy to give you this chart. Select what you want. Then it gets easy. If you do not ask, you will not get. That's what I'm trying to tell you. It's not that you sit at the back seat and then tell, hey, drive here. The driver doesn't even know where to go. He'll blindly take you to wherever he wants. So if you want something good, if you want to deliver a class of dentistry apart from others, you need to sit back and do some research and find out. Get a chart, select the right material, what you want. Now look at this. Somebody had done zirconia crown and then it broke. It was strong, it was promised. Why it broke? Because of some anterior guidance issues. So there was a envelope of function constriction and the crown broke. So I had to change the crowns for the patient. And how do you select which crown to do for this case? Emax is a good choice, yes. But here there was a problem that we had to join these two crowns because of technical reason. The crowns were getting thinner and we had to join so that the constriction of motion of the envelope of function and the constriction of the mandible to be avoided. So we had to opt for zirconia in this case. So it is all scientifically based. That's why I put a disclaimer in the beginning that these are all scientifically based and not, I'll do zirconia for this case, I will do Emax. No, look at that. That's all. You need results at the end, which will stay. Accordingly, you do. Again, when you come across discolor, such heavy discolorations, it can be done only with zirconia. So it is not that I always stick with Emax. It's not that I always stick with zirconia. It is situation based. I don't have my own personal preferences. This is not my house to do. This is my office to do dentistry. These are my patients. So this was, I love showing this case because this was my case done by me. The layering, everything was done by me. This is where I learned, and the entire crown was done by me. So we have our own laboratory. We have our scanners. We have 2 scanners, Ivoclar scanner and the 3-shape scanner. And we have the entire laboratory system here. We have everything within in-house, so we can work and we can do everything. I generally sought to do all layering techniques, but staining I'm still learning. So everything is possible today. So when it comes to bigger cases like this, it's all fixed dental processes. Fixed dental process, you cannot play around with glass ceramics. The only option is better is to do with zirconia. So here is a case which was rehabilitated, smile makeover with zirconia. Look at that. So it is zirconia, then I layer wherever required, I paint wherever required, and then deliver what is required by the patient. So today, there is a good option that is available. Please understand this. When I'm doing a canine to canine or premolar to premolar fixed dental process, let it be upper or lower, just feel that processes in your hand. You will feel slightly heavy. It's because of that strength, it gets heavy. So today we have gradient zirconia. What is gradient zirconia is that the block, right? You have the disc, right? Half of the disc would be 1200 MPa, the 3Y, because that's a base of the bridge. The remaining half would be 5Y, that is 650 MPa. That means the strength is reduced, but the aesthetics improves. So it's like a porcelain fused to metal, but in the same block, the metal or the zirconia, which is strong in the base, which doesn't come in the opposing layer. When it comes in the it's like a stainless steel table with a glass top. That's all. So what happens is that aesthetics improves, the function improves, and you don't have to layer. Without layering also, it comes very, very beautiful. This is the most expensive zirconia that is available in the market today. Okay. So when somebody's, I don't even know how these, because everything is done in-house. So I don't know what these lab guys are selling. I don't know in what name. You will have to know it's a gradient zirconia or no. Please, gradient zirconia will give you beautiful what you're looking at here. This is again a process is done by us. You can see the incisal edge is much more translucent. It's giving aesthetics. Nothing was done. It was just painted, and the gingiva was done with the red stains, and the automatic other stains were incorporated within the block. I don't have to do anything. So when the strength increases, we have also these colors coming up like dentine, and when you go there, it is all monolithic. Monolithic means what? Without layering. So the concept why that is coming is more and more the fabrication process they want to ease out. So that's why when it's digital, the fabrication, the amount of fabrication that is required by a laboratory is getting, so the amount of fabrication required by a glass is much more when compared to zirconia. That's why even if you want to do a glass, these technicians will convince you, doc, why do you want? I can do the same thing, get it done with zirconia. It's a sad story. Sometimes people get convinced, but I stick on to what I want, because when doing a laminate, when my aesthetics is high and it's a bonded restoration, I always want to wind up with glass ceramics, and then I want to do the layering. I want to do the micro layering. So keep that in mind. So what can I fabricate with zirconia? I do not prefer to do all these smaller restorations with zirconia. Definitely a crown. I don't mind you doing posterior crowns, anything. But only request is that please select the low strength zirconia. You don't have to use 1,200 MPa, which is still available in the market. I don't know, they give it for 1,000 rupees or 900 rupees. That is a high strength zirconia, which is not at all warranted. So please make sure that you do a crown with a low strength zirconia. When it's a bridge, if it's a 2 unit bridge or something, then it's okay. Don't push to gradient zirconia, because gradient zirconia, I think the lab will definitely charge you somewhere around 5K to 6K. Patient has to pay so much. So again, please go through the manufacturer's instruction, because every company would have something. Maximum is to replace only 2 teeth. So you can do a 4 unit bridge in a posterior. Beyond which, please check with the manufacturer's instruction if that particular material would allow you to use this particular material for this case. Otherwise, the last option is always metal ceramics. So metal ceramics will never leave us. It'll always be with us. So metal ceramic will stay when I have to do multiple processes. So metals will be there. The only thing is that we don't do casting, we do DMLS technique today. So please remember what all you can do. So before I conclude, I want to show you something that I actually told a disclaimer. So that is very important. A disclaimer is I have not told you to use Emax or zirconia anywhere. Got it? It is the choice what you make. So the argument always continues, shall I use this? Shall I? It's not your own whims and fancies or bias. It is what that particular case warrants. So please understand, both can also be matched if you have a masterclass technician. So this case was a complex case wherein the right side of the mouth, 1 1 1 2 1 3 required laminates, which was done by Emax, and the replacement of the tooth to the fixed dental processes was done with zirconia. So this is what is the case, and that is what you see. Half of the mouth is done with the Emax, and the remaining half is done with zirconia. Everything is possible. Everything is today science-based dentistry. So guys, it is very important that we communicate properly to the laboratory to get the results what we want, because you see half of the tooth is Emax and half of the tooth is zirconia. I'm not against this material. I'm not against that material. I'm against people blindly doing cases because I love zirconia or I love Emax. That is not the story here. You knowing how to select the material, how to do the processing technique, and accordingly able to do all these stuff is very, very important for us. So please understand the science behind all the materials, and accordingly we will be able to deliver what the patient is required. So please, it is a huge gap that is missing these days, because the gap between the ceramist and the clinician. If this gap is not bridged, we will not be able to deliver what our patients are expecting. So also please remember that there are two things first, the analog and the digital. Of course, today it's all digital. We do all digital workflow. End to end, it is digital for us. Nothing is left like that. So we have everything digital, digital, digital. But please remember that that 20% of the human touch from brain to fingers will make the final difference. So I saw this picture on Instagram. Uh, I don't have to talk much. Manual makes a huge difference. The final touch by the hands will make a great difference. So it's not about analog, it's not about digital. You process your illustration. Finally, how we bake the cake, layer them, and do them so beautifully will make a huge difference in the final outcome. Everybody does a smile makeover, everybody does a full mouth reconstruction, everybody does everything, but your outcome totally depends upon the science that is applied to the clinical dentistry, what you've been doing. I hope this presentation was useful for you to open up your eyes and see what is available today and clinically choose the material and not blindly choose. So I spoke about bridging the gap, guys. I'm really, really happy to invite you to this conference that's going to come up in Cochin on Feb 3, 4, 5. We have beautiful speakers coming from US, Spain, and Canada. Two technicians are there with us, and all your questions will be answered in this 3-day conference. We don't have multiple speakers. All these 5 would be taking care of complete 2.5 days. It'll be a worthwhile conference to attend. It's Feb 3, 4, 5. It's very close now. We're all gearing up with the final arrangement. So it's really the bridging gap. There are 2 technicians and 3 clinicians who are going to talk. We'll go to talk about indirects completely. So it's worthwhile attending. Anybody interested can visit our website, www.acda.co.in, for further details. You will get all the information. As the president of this association, I warmly welcome each and every one of you for this. It'll be a real learning experience. It's a worthwhile learning experience. I would like to thank the participants during this late night, spending time for education. Really happy that so many of you are there. Really thank you guys, because education is the soul of any clinician, and online dentistry for creating such a beautiful platform for learning and giving me this valuable opportunity this Wednesday evening to share something what little I know. Any questions, I'm more than happy to answer. You guys can also follow me in my Instagram at drmohanb and chat with me any doubts, because I know there'll be a lot of doubts coming. I'll be more than happy to answer. It's not that if you message me, I'm not going to reply at all. I'll be definitely happy to message you back with the doubts what you have, because that is what we take up as a duty. Knowledge is not constricted to one person. It is a legacy to continue with the generation. So we are trying our level best to spread our knowledge so that the legacy continues and the quality dentistry continues. Thank you guys. Thank you so much.
Thank you, sir. It was indeed a wonderful session. So let me check the chat box. I think we have so many replies there. Thank you, sir. Thank you, sir. I don't find any queries for now. Yeah. Yeah, so we have a question here.
Yeah, please.
Yeah,
I'm happy to answer.
What is the bonding protocol of lithium silicate?
So lithium disilicate is a bonded ceramic. So what do we do is that we can etch them. We can etch them with hydrofluoric acid. The percentage is 5 to 9% of hydrofluoric acid. We can etch them for 15 to 20 seconds, wash it off completely, then put them in indirect ultrasonic, clean it up, get the white frosty appearance. Once we get that etching done, then we put the primer on top of it. The primer is a silane methacrylate. We apply silane methacrylate, wait for a minute. Once that settles, we etch and bond the tooth structure, and then we put the resin cement and then fix it. That's the way we bond lithium disilicate.
Yeah, so I think so many thank you messages, sir. I think so we are done for the night. So thank you,
great.
sir. Thank you.
Any
everyone.
other questions, they can keep messaging me. I'm absolutely more than happy to answer at Dr. Mohan B.
I think just one last question, sir.
Yeah, no problem, please.
What is best luting cement for zirconia, resin or resin modified GIC?
I would prefer a resin, because when you're looking into a bonded zirconia, then resin. If it's a regular crown, retentive crown, like what you're doing, then even glass enamel is enough. You don't have to mix both. Either you choose resin when you're doing a bonded zirconia. If the zirconia is all fine, retentive on its own, then finish it off with the glass enamel. That's more cheaper for you. You don't have to complicate with resin modified glass enamel. That's a good question. Thank you.
So another question, sir. How to know which strength zirconia lab is using?
Actually, since I have my own laboratory, I have no clue what these guys are selling. It's simple. When the cost increases, strength decreases. So when somebody's coming and selling you the costliest zirconia, please understand the costliest today is a gradient zirconia. The second would be a low strength. It's so unfortunate that the low strength is high cost. That is
Look.
what is the story today. So if you are choosing 1,000 rupees zirconia, that is a high strength zirconia. That is how I grade it. Because a
Yeah.
guy who comes to you, right, he will not have any knowledge of all this. For him,
Uh-huh.
it is platinum, premium, or whatever they call, right?
Yes.
That is
Yeah.
all. He doesn't know what goes inside. But
Uh-huh.
a simple equation for me is that which is cheaper is stronger. That which is stronger is not looking good. That's all. I will wind up the equation in that way.
Yeah, sir. So, and another question, sir. Can you please suggest, is there the need to use bonding agent while cementing zirconia with RMGAC?
Not required. With RMGAC, it's not required. So when you're doing a crown which is not going to stay on its own, then probably you can think about it. With RMGAC, please not required. Not at all.
Okay, thank you, sir. So, thank you, sir, for staying so late with us.
No,
Thank you all for
absolutely. It was a
joining.
pleasure. I should thank you guys.
Thank you, sir, for joining. It was a pleasure having you here, sir.
Thank you so much.
And
Thank you.
rest of the participant, thank you for joining with Online Dentistry at 9 p.m. So, stay tuned. Good night.
Good
Take
night.
care.